Okay, so I'm going to get started. So hi everyone, my name is Ashleigh Welter, and today I'm going to be presenting to you my case study. She was a patient with Guillain-Barré syndrome in the inpatient setting. So to start with the purpose of the case, it's to present an educational case study to facilitate discussion and critique of evidence-based therapeutic activities, exercises, and modalities which aided in increasing lower extremity strength to improve function and expedite neuronal repair and growth in GBS or Guillain-Barré syndrome patients. So in other words, I wanted to examine the literature and its application to this case and the interventions used to put the patient at a level of function for success upon discharge. So a little bit of background on what Guillain-Barré actually is. It is an inflammatory demyelinating polyradiculopathy, which causes acute flaccid paralysis. Its onset is usually post-infection, either GI or respiratory, and occurs due to a heightened immune response, which then leads to an autoimmune response triggering ascending numbness, muscle weakness, and limb pain. With my patient, her symptoms began as lower extremity weakness, and she was unable to stand. It then progressed to more severe ascending weakness in the arms and legs, and she had upper extremity and lower extremity limb pain. She described it as like a burning pain. She also had no true infection per se, which triggered the attack. I'll go into that a little more later when I go over her history. So nadir or peak weakness occurs 2 to 4 weeks after initial onset of symptoms and then gradually improves following weeks and months. There are several medical interventions which have been shown to slow the autoimmune response. The more popular ones including the intravenous immunoglobulin treatments or IVIG treatments, which my patient did receive for 1 week while she was hospitalized. Also plasmapheresis and corticosteroids have been shown to be helpful for some types of Guillain-Barré as well. Okay, so for a little bit of history on my patient, she was a 34-year-old female who was diagnosed with GBS on the 8th of January. And again, stayed in the hospital for 1 week and received 3 IVIG treatments. She was then discharged home for a few days prior to coming to inpatient rehab, and that was just due to insurance purposes, some kind of lapse in insurance. So when I evaluated her, I learned she was a 5th grade teacher, a mother, and a military spouse. Her significant surgical history is listed here. She had her gallbladder removed 10 years ago, and she had a gastric bypass a little less than a year ago. The doctors told my patient that the gastric bypass surgery, whether it's the actual surgery itself, the weight loss, or the alteration to the GI system could have potentially been the trigger, but that was like a year ago, so I'm not sure. I could not find any research correlating the two. Significant medical history includes arthritis, which occasionally acted up when the weather was one of those ones, and from prolonged sitting, of course. And then she also had a severe bout of vertigo, which onset at the end of November and lasted for 3 weeks, which was almost 1 month prior to the onset of symptoms. So the doctors also told her, this was all from her telling me, that also could have been related, but I did research looking at any type of vertigo and its relation to GBS, and I also found no evidence to support that either. So no true infection. So a little bit more history. She was independent prior to onset in all indoor, outdoor community mobility. She was not driving, though, due to the bout of vertigo. It got that severe that she was uncomfortable driving. After onset, excuse me, after onset, she acquired a standard walker. She borrowed a wheelchair from a friend, and they installed grab bars in her bathroom. She lived in a multi-level home with her husband and her 9-year-old son, with the primary bedroom and bathroom on the 2nd floor. Prior to coming to inpatient, that small stay she had at home between coming to me, her husband was supervising her walking with the walker, which is not too safe, and he was carrying her up and down the stairs, and he was max lifting her for all transfers. So it's kind of romantic, but it also wasn't safe. For her stated long-term goal, she said she wanted to walk and return to all activities without help. I put the goal I developed here, the main long-term goal I developed here, though I did not write it till after the evaluation, of course. So the goal I wrote for her was to be able to transfer sit-to-stand MODI with the least restricted assistive device in order to increase functional independence. I also wrote several short-term goals and long-term goals that address bed mobility, wheelchair mobility, transfer stairs, ambulation, all that stuff. And those were modified on a day-to-day basis based on her progress, all accumulating up to her being Mod I in these activities. So for my objective findings, lower extremity range of motion was generally within normal limits. She had some hip flexor tightness, some hamstring tightness. Of course, she was bedridden for a week and she's been sitting in the wheelchair. So that was to be expected, but nothing huge. I did a gross assessment of strength with my findings in the red chart. You can see everything is relatively weak, especially the knee extensors, which of course is crucial for walking transfer stairs. Intake was intact. Her sensation, her light touch was impaired bilaterally, and proprioception was intact on the left, but impaired on the right up to the ankle. This was extremely difficult to measure since even like the slightest light touch was extremely painful to her. It elicited that burning pain. Again, the right was worse than the left. It had been shown in the research that I did that impaired proprioception was related to a longer stay in inpatient rehab. I point this out now just because this is here, but also this is like only one of like the one negative prognostic factor I found for her. So that was a good thing. So for her sitting balance was excellent. She was able to sit on the edge of the mat without support. She was able to shift her weight. She used her elbows to kind of maneuver herself up since her hands hurt when she touched anything. Standing balance was poor. She needed bilateral upper extremity support all times from the walker. She stood with moderate trunk flexion and with her weight shifted posteriorly in order to hyperextend her knees so she could balance. She could only achieve single leg stance if there was bilateral upper extremity support, which was the extent of our formal balance testing. In order to have that leg locked out, she could do the single leg stance. Gait analysis was done too, of course. I have a picture later in the presentation of how she walked, mouse prod walker, so I can show you guys if you guys wanted to see. But she ambulated again with that moderate trunk flexion, which allowed that posterior weight shift and the knees to lock into hyperextension. She'd then kind of pendulum her leg forward until it hit under her. Then she'd, of course, slap back into hyperextension. And this is what she'd been doing at home as well before coming here. So, again, and not the safest thing, but it was how she was getting around. So, for my functional outcome, we used the FIM to track progress on initial evaluation and discharge. This is what the facility used, but it's also been shown to be a great tool to track functional progress for specifically GBS patients, not only inpatient rehab in general, but for them. So the list on the right, contains just some of the functional components which we measured, along with some FIM components as well. It's like she needed to be able to get in and out of the car when she left, so we worked on that. But the chart on the left contains the mobility portion of the FIM, which the PT was responsible for grading on initial eval and discharge, and those were the things that went into our functional outcome. So as you can see, she was max assisted total for all standing activities. She was total for stairs, and we somehow got up magically with my CI and her and me, and then we just had to carry her down because we couldn't get down, but we thought we'd try. She wanted to try. So, so functionally, if you look at those scores, she's at ground zero functionally. So for the evaluation, so this slide hits on the ICF model and it incorporates the impairments along with the biopsychosocial aspects of this case. We have her health condition and the extensive list of impairments, which were now limited, her activities and participation, which were now limited due to these impairments. I listed the environment she was going to be functioning in for the next few weeks with us and then also upon discharge, which was important when considering the functional interventions we were going to do, and along with the personal factors which affected her morale and motivation throughout her stay in inpatient rehab. So again, her medical diagnosis was the Guillain-Barré. I listed below the PT diagnosis, which we developed after eval, which was severe lower extremity weakness, impaired sensation, pain, and poor balance, limiting function. After considering all the impairments we found during the evaluation, the primary one I think limiting her, of course, was the severe lower extremity weakness, primarily with the focus in the knee extensors. For prognostic factors, there was a lot of positive factors for her, which was great. She was healthy and active prior to onset. She was extremely motivated. She had a supportive family. Her onset of symptoms was slow. She is young and she had no reported diarrhea or GI bug, or she wasn't positive for the one on the bottom. I'm not going to say it because I'll butcher it, but that's the one that's been related to the most severe cases of GBS. So all of those were in her favor. So that was a good thing. So potential barriers that I considered after the evaluation included the severity of her deficits, primarily in the quadriceps, which was present in both legs. Another was the limited time she had in inpatient rehab. We had 3 weeks based on the plan of care. So function and independence needed to be a huge focus for this short time frame so she could actually do things when she went home. The work-rest ratio for GBS patients was also something we needed to consider with her since inpatient rehab is so intense. We need to be careful not to overwork her as we could damage or potentially reverse gains that we actually made already. She also had severe neuropathic pain in her hands and her feet, along with poor sensation, which of course led to really decreased stability when she was walking. So she's walking in her like non-slippy socks all the time, which wasn't good. She was also unable to tolerate shoes, which I think would have been extremely helpful for her, but we just couldn't get them on. So that was kind of a setback for us. So for the plan of care, of course, as I said, the focus was on function, safety, strength gains, and independence. I recommended 3 weeks with 90 minutes a day with at least 5 days a week of therapy. She also had OT for 90 minutes a day as well. Focus was going to be on safety and independence during the ambulation due to the patient's stated goal and her current level of mobility. Along with focus on the FIM gains, because that was first of all our functional outcome, and then it was also important because all of those activities she was going to need to be able to perform at home, hopefully by mod I level when she left. So here, does anybody have any questions before I go to the interventions? All right. So this is a little dense, so if you guys do have questions, you can stop me during, and I can show you since I brought the walker, so just let me know. So we came up with several compensatory techniques for her to be able to reach her goals, along with increased independence and decrease the burden on her husband having to basically carry her everywhere. So for the transfers, we started sitting on the mat table in a heightened position and worked on forward weight shifts until her knees were locked out completely. She would then crawl up the walker into standing position. So she'd use those lower bars and then crawl up that way. We practiced this from various heights, and she became proficient even from the lowest mat surface, which is kind of equivalent to like the edge of a bathtub, is what I put it as. And then she could even get up from the couch. So that was great for her. For gait training, we never walked more than about 100 feet per session, just because it wasn't completely safe, and it just really, it looks like that picture, and it just was really, the knees were just like really getting stressed. She never complained of knee pain, but I just didn't want it to happen. So yeah, the picture is similar, and I explained the gait, but again, it was a lot of weight through her arms, and it was painful both to her hands and her feet. If she didn't have her footing right, usually what would happen was her ankle would roll, which is another reason I wish we could put shoes on, but her ankle would roll and then her knee would buckle and then I'd have to catch her. So the first week, it was extremely close guarding for her when she was walking around. It was something though that we decided she needed to be able to do at home, and it was her goal. So in the end, we did limit gait training with a lot of education on safety and limiting it at home unless she needed to do it. We also had to develop a compensatory technique for stairs. So during one of the last sessions, she was able to go up and down 6 stairs, contact guard assist, which was awesome. She was very proud of herself, so that was good. She again used that trunk flexion in the knees to balance. We trialed TENS for pain control, and I wanted to do orthotics as well, just some simple AFOs, just so we could stabilize her a little bit. But she couldn't feel the TENS on the highest setting, so that wasn't something that was useful for her. And she did not feel comfortable wearing the orthotics at all. She really didn't like that idea, so we decided as part of patient values, being a part of this whole experience, that we would ditch those I did educate her on them, though, in case she wanted them later to tell the home health PT. So we also did, of course, wheelchair mobility. We did fall recovery, supine and seated TheraX, and manual therapy. So going a little bit more into my interventions and which portions were evidence-based. We did submax gravity eliminated strength training, mostly for the quads, and gravity resisted for stronger muscle groups. This has been shown in the research to facilitate proper growth and repair of the neurons without overstressing the system, just doing it in a plane where it can happen without having to really push it. We performed PNF patterns, assisted and with manual resistance through ranges which she could tolerate. So we did both D1 and D2 flexion and extension because it was shown in the research also to be beneficial for those neurons to do those multi-plane movements. It also showed that training fast twitch fibers in these multi-plane movements were beneficial. So when the patient could tolerate, we performed quick pushes through the PNF patterns, and then we followed them with slow and controlled ones. Bicycling was also shown to be beneficial for regaining strength, along with improving activity tolerance, which was my main reason for doing it. Especially just because it was a safe way she could sit down, she could do it for a good period of time, and it kind of counteracted that bed rest and wheelchair confinement that she had going on. I also use facilitation techniques occasionally, especially on the right lower extremity when performing those long arm quads and sideline. I mainly use a quick stretch technique to the knee extensor group to recruit them, seeing as that quick stretch kind of activates that spinal reflex and kind of permitted her to move through that range of motion. Usually I only need to do one of those, and then she could participate fully in that exercise through the rest of the session. We also used heat, mostly on like her quads and hamstrings, to counteract the soreness, which was noted after therapy sessions. I found research saying this can aid with DOMS and pain control, however, nothing in particular on neuropathic pain and it being beneficial for neuronal repair, but it helped her be able to participate better the next session. It also decreased her pain level significantly. And of course, the focus of our therapy was functional training, which the literature deemed the most important type of therapy for this patient in regaining strength and mobility. We also use manual therapy techniques, of course, to decrease tightness in the hip flexors and the IT band and hamstrings when the patient was feeling sore, which also helped her maintain her range of motion so she could perform those kind of transfers and that walking pattern despite her mobility limitations. Okay, so kind of key points. So there were some key points from the literature or guidelines which were mentioned that we kind of disobeyed a little bit, which was avoiding overworking muscle groups, being cautious with eccentric exercise, and having full anti-gravity gains prior to progressing to standing or walking. So that was mentioned in the couple papers that I found. So during her stay, we really pushed these points, seeing as almost all functional activity required eccentric contractions. And she did not have full gravity limit gains prior to standing activities. As you can see, she had the 2+ in her quads. This was something we had to juggle, especially since we had such limited time with her, to either follow these principles or modify them to allow for the functional gains to happen, which is something we did. However, focus on safety, such as limiting the walking, don't do this at home unless you need to go to the bathroom urgently type thing, like let somebody help you, was something we relied heavily on as well. So progressions were based on day-to-day presentation of the patient and were primarily focused on function and independent mobility. So as strength and confidence progressed, we progressed repetitions, resistance, duration. I break all these up based on tolerance, moving between like seated supine TheraX to standing functional activities. If she was sore and couldn't do the standing ones, then maybe we just did more supine ones for the muscle groups that weren't as sore. So modifications were made to the plan of care based on the daily presentation, along with setbacks. About 4 days prior to discharge, she fell in her room when she was transferring from sit to stand from her bed to use the restroom. She told me she got up too quickly and rolled her ankle, which was the lack of having shoes, but she rolled her ankle and she went all the way down to the floor. This was a setback for her, for sure, and required reassessment, encouragement, and motivation for myself and other therapists as well to build her confidence back up to where it was the next 2 days before discharge. The reason for the fall is something we addressed in PT afterward. So the next day after I read the note, we kind of went over what happened, taking it slow, double checking her knees. She was kind of getting overly confident because she hadn't wavered or fallen in like a week and a half. So she was like, I got this. The family was also present at some sessions, and when they were present, I allowed them to walk with her, practice with her, which also allotted some modification to the plan if they had questions or something while they were there. So I started with showing you her strength gains, but I mean, it's not really strength gains, but it's more like neuronal, maybe reinnervation to the muscle happening. As almost all muscle groups performed better during this assessment at the end. Knee extensors were the most important, seeing as those were the most limited at initial evaluation. But she was able to perform full range of motion in a gravity-eliminated position and even kick out a little bit against gravity when she was about to leave, which was a huge accomplishment for her. It wasn't any type of functional gain whatsoever. She still couldn't stand up, but it was something for her that was motivating. So here are those functional things we measured at evaluation along with some of the thin components. She improved on everything and was supervision to MOD-I in all aspects except the stairs. As I said before, she was contact guard assist on 6 stairs one time, but when we were evaluating on discharge, she got stuck at the top, and I think it was because she was scared to fall. It was like 3 days ago, so it was still like I'm at the top of the stairs and I don't have quads, so I just lowered her down and bumped the rest of the way down. So, and we practiced bumping, so that's what she was going to do at home anyway, because I think that's just safer. So we practiced that, but that kind of made that score a little better, but it was still improved from when she came. So the progression on the outcome measures, the initial FIM score was 10, and that was for the mobility portion of the motor FIM. So there's a lot of components to the FIM. A statistically significant change would be 17 points in the motor FIM. The motor FIM is made up of things that OT measured, which include self-care, grooming, toileting, and then my portion. So she gained 9 points just from my portion. So if we added in OT's notes, which I didn't look at, it could have been a statistically significant change, which shows that, I mean, we were really helping her work toward what she needed to be able to do at home. So for her home exercise program, we instructed her to rest in the room after all therapy. She was the type of person who would go in the room and continue doing like bridges on the bed and like kicking her legs out and trying to do stuff after PT. So where she was instructed to rest. We did set up home health PT post-discharge. She also got OT, and she was instructed to continue to perform the supine and seated TheraX we performed in the clinic, since she would not be seeing the home health PT as much as she'd be seeing me if she was still there. The exercises that we told her to continue were listed below. I also told her to continue performing the functional activity we did in the clinic, the standing ones, but to wait for the therapist, the OT, the PT, or her husband to be home if she decided to do any of that. So looking back, what I could have done differently, I definitely think I could have been a little bit more function focused. I know the seated and supine TheraX was extremely important. I just think I could have worked a little bit more on like fall recovery, that type of thing. Functional training was the most important, and that was restated in the literature multiple times. So that could have been something I focused more on. I also don't think I wrote her goals in a realistic manner. On initial eval, I said she's going to be MOD-I for everything when she leaves here. But that was definitely not realistic, and I think it was part of me not being experienced in that setting and not being experienced with that type of patient. So that really was a learning moment for me, and it helped me appropriately write goals for the rest of my clinical. So looking back, a summary of everything. She was a 34-year-old patient with Guillain-Barré. She had severe lower extremity weakness, impaired sensation, pain, and poor balance limiting function. After her stay with us, she made functional gains in all FIM categories and made increases in lower extremity strength and decreased her neuropathic pain in her legs. She was also able to achieve her personal and our long-term goal successfully. And there are my references.
What orthotics did you try?
They were just like plastic AFOs, like the super cheap ones that we just carry to give to somebody to go home with.
Did you have an option to try KAFOs?
Not there. I would have had to like order them. We would have had to order them because all we had were just like the plastic. They were like PSLs or yeah, posterior leaf strength. Yeah, they were just like super. But even then, I like showed it to her. She was like, no. It almost elicited tears. The thought of having to put that on.
Yeah.
So we were just like, okay, well, this will be helpful.
Lasers, nothing, she just didn't want anything.
No, we even like tried to like consider maybe like a Swedish knee cage or something for her leg, just so that it wasn't so bad. Because I mean, I told her, I was like, this is what's happening to your knee now, and I know like you're gonna go home and walk anyway. So I'd rather you like do it here with me, and you know we get it down here. But please limit it at home like as much as you can, so that first of all you don't fall, and second of all you don't have chronic knee pain for the rest of your life because you walk like this for 4 months. So. Yeah, the orthotics, I started to introduce the AFO and then I saw the reaction, so I just backed away from it.
And that's part of the decision-making process.
Yeah, which I don't think, I wish it wasn't that way because I think she would have been much better off with it, but
there wasn't an opportunity.
maybe later, and that's why I told her to keep her mind open when she got home for the home health PT because I'm sure they said the same thing. So.
Anybody else?
Nicely done.
Thank you.
For sharing that.
Thank you.
One of the questions I have is, in your patient education and in the literature, how do they define overworking from that intensity of too much?
It was all patient self-report, and that's something we educate around to. I'm like, look, you've worked out before, you know what feeling sore feels like or being fatigued feels like. Her sister was a PT, so like we talked on the phone and she talked to her on the phone. So it was like when she was educated, she knew what was happening. But it was all like, how are you feeling today? You know, we used the Borg scale a couple times for like, it wasn't the Borg scale because it wasn't exertion, but like, how are you feeling on like a pain scale, like soreness wise, how are you feeling today? Okay, where is it? Okay, maybe we're gonna back off that today, or we'll do a little bit more stretching there, and we'll heat it while you do the bike or something like that. So it was all based on her report.
What objective measures could you use?
For pain,
No, for her progression.
for progression, I mean, we use
For recovery.
the recovery.
Okay, how long post nadir was she?
So she
Vice versa.
probably like a week, like 2 weeks probably. Because she went to the hospital after, like, I think she was like at her worst by the time she got to the hospital already. It never progressed past like arm and leg weakness. Like she never had anything so severe. But I think she was probably like 2 weeks past nadir at that point that I saw her.
So you're making a guess that it wasn't in her.
No, it wasn't, because they didn't really know what it was and she waited so long. She initially thought like the weakness was from her being bedridden from the vertigo. Like that's what she attributed it to. So it could have started all the way back at the vertigo because she was just laying in bed. So I didn't really delve. I mean, honestly, I didn't really delve that deep into that. I took what I got from the eval and I went with it, so.
And from your readings, in 3 weeks, if somebody was from 2 weeks post nadir, so now like from 2 weeks to 5 weeks, what changes would be expected?
Yeah, so that was the thing. There wasn't, she's not gonna have huge changes in any type of like muscle activation, strength, anything like that, or even in her pain, just having 3 weeks with us and being that close to where the peak was. So basically that's why we came up with so many compensatory things for her, because I mean, she had that small increase in strength with us, but that was really the only thing. And then the functional gains, which was all because of the compensatory things that we did. So really the research, there's really nothing we could have done except helped her function at home better. I still did the supine and seated there because like I was excited to do like the PNF patterns and like all of those things. I knew they weren't going to make that big of a difference in that short time period, but I mean, we still did them.
My concern actually is that you overdid it, and that's why she had no strength.
On the walking or on the?
Yeah. And I don't know that, of course, you're the ones who were there with her, but I'm just wondering, why, when she had less than 3,
Mhm.
and a terrible gait pattern, you were worried about her knees, she's rolling her ankles. Could you, and I guess I know she has a 2-story house, but like while those muscles and nerves are recovering, could you have done wheelchair mobility so she's using all 4 limbs, so it's not so taxing?
Yeah.
It's more safe, and taught her, like squat with the transfers where she's got 4 points of control.
Mhm. I mean, we did all of that too. I mean, she could go up a little ramp, she could go over door sills, she could go over carpets in her wheel. She was very proficient in the wheelchair, and that was gonna be her main, we ordered her a wheelchair, because that was like, this is what you need to use at home. She borrowed one from a friend, so she had one at home, but we ordered her one. We spent a lot of time doing that. Honestly, I don't think we spent more than like maybe 15 or 20 minutes a session doing like PNF patterns or like seated or supine therex. We didn't do a lot, and she was really good about telling me, this is feeling sore, this is feeling weak, I'm tired, let's rest, we'll go do wheelchair mobility. So I guess I went off more patient report. I had never seen a Guillain-Barré patient before, so honestly, I didn't know. I spoke to my CI about it, but like over work-wise, her report, and she was still making gains, it seemed like it was reasonable to me, and of course my CI too.
Her initial film, was she by her wheelchair mobility? No. Okay.
She still needed help like learning to turn, so I had to help her turn. So that was pretty much the only thing. She could propel. She didn't want to use her feet to propel most of the time because it was painful to touch her feet on the floor. So we gave her gloves, which helped her use the wheels more.
It's the walk. Probably water.
If you want to see the walk, it's exactly like that picture. She would basically walk like this, and then her leg would swing forward, and then it would hit back. It was not good. But I mean, she was doing it prior to coming to see me, even. So it wasn't our idea initially. So.
And that gait is fairly similar to anybody who's really big quads. That's they're compensating the best they can. That's,
It kind of showed me, again, that patient value sometimes ruled.
Yeah.
And that was so valuable for her to be able to do that, that you had to modify some cases.
She was a fiercely independent person. So she liked being carrying up the stairs, but she was pretty independent.
So I'm getting the sense that if you hadn't addressed it, she would have done it herself and done it unsafely.
Oh,
Is that
She would have
correct?
done it at home, even though her sister was like, don't, be careful, because her sister, I think her sister did home health. She's like, be careful, be safe. But I mean, I feel like I can't tell her, even if she was going to do it on her own, I can't tell her, please never stand up on your own at home when nobody's home, because her husband has to work. And she could do it, and she could do it safely. It just wasn't the best thing. So we just did a lot of education on, please don't do this unless you have to, or unless there's a therapist or your husband right next to you. So I got the impression she would have done it anyway, but
Did she know she could be making herself worse if she was doing it?
at home, I mean, we educated a lot on the overwork, but I didn't tell her like you're gonna make yourself worse.
Slowing her progression?
It was more like, I don't want you to fall, was my mindset more so than anything.
Were there any discharge options other than home after inpatient?
I don't think she was low enough level for a SNF. So home would be fine. She was gonna be fine with home health. I felt perfectly safe sending her home with home health. Her family was there, they knew what to do, they knew. So I felt fine sending her home that way.